I'm here to talk about TAVI, of course, which is not about techniques. I'm not going to talk about techniques. I'm not going to try to prove that TAVI has a place, because that's been done. And my conflict of interest is that I don't do operations and I implant TAVIs. So I'm going to talk about who should or should not, interestingly, have TAVI in 2024, where it should be done, who should be doing it, and how it should be done. And as I think the last discussion was alluding to the fact of lifetime management of aortic stenosis, I think we need to move in that direction, because all these techniques that we have heard from surgical colleagues and TAVI, they're all complementary in terms of decision making in the patient. So I'm going to start with a scenario that I'm not going to go in detail at this point, and then I'll talk about TAVI. Of course, we're talking about an older group here, a 72-year-old female. She has had aortic valve replacement. It's a small valve which failed for very obvious reasons. As you can see, it was trifecta. There wasn't, despite being a small valve, she never had any evidence of patient-prosthetic mismatch. And now she has biprosthetic failure with severe AS, and her surgical risk is intermittent. So while that scenario is in your mind, I'm going to talk about where TAVI stands right now. So this is a summary of both American and European guidelines. And you'll see that this expected survival in conjunction with surgical risk is the way to assess who should have TAVI and who should have SAVR. It's no longer just about the surgical risk for very obvious reasons. And that's because the randomized control data has shown that TAVI has role in all surgical groups. So then it becomes about the durability of valve or expected survival. So if I have to summarize this, in Europeans would say if you are age less than 75 and your surgical risk is low, then you should go ahead and have surgical aortic valve replacement. And then surgeons can decide, techniques, aortic enlargement or not. Americans would say that if you are less than 65 and your survival is expected over 20 years, then you should go and have SAVR. And again, the details of that will be up to the surgeon. And you can see they're dividing in terms of putting emphasis on expected survival versus expected survival and risk. But it's more complex in real life because not many patients would just have isolated AVI. You would not be making those decisions just because of the expected survival or what's the risk of the patient. So this slide summarizes what other factors would play part. For example, the valve morphology. Bicuspid aortic valve can be completely different ball game. The other emphasis is on access, how the TAVI can be performed. If it cannot be performed through transfemoral access, then you have to reconsider other factors. Concomitant valve disease. Very often these patients would have other valve disease. They would have coronary artery disease, and the debate of coronary artery disease, whether they should have bypass graft versus stenting, would come into play. And there are other factors such as endocarditis or previous surgery, limitations for surgery. On the right side, I've got an anatomical criteria, which is important to mention, although the TAVI has been evolving, and all these anatomical criteria which were excluded as a part of randomized controlled trial between TAVI and SAVR are actually common occurrences in day-to-day MDT. So all of this has to be taken into account. So how we do TAVI nowadays? Of course, there are no sutures, I'm sorry, involved in this. The sutures that we do put in, we don't have to tie them. They come with pre-placed knot. It's done under local anesthetic in almost all cases with some conscious sedation. It's full percutaneous approach. There is no longer role of cut downs in over 95% of the cases. And they don't need transesophageal echocardiography anymore. They can be done with the transthoracic echocardiogram. Where we are implanting them, then we, just like it was mentioned earlier in the discussion, that we moved on from just implanting the valve to a state where we're considering what would happen to these patients in future. For example, what is their age, what is their expected survival, do they have coronary artery disease, would they need access to the coronaries, how long we expect this valve to last, and would they be suitable for redo TAVI should it be needed. And then in terms of planning, CT plays a very important role, and I've highlighted in the image on the left side the things that we need to consider: vascular access. Do they have conduction abnormalities? Because TAVI is associated with much higher risk of requiring pacemaker than aortic valve replacement done surgically. There's a risk of coronary occlusion. It's very low, about 1% or less. And there's a risk of annular rupture. So all of these factors have to be taken into account at the time of planning for the procedure, which happens before the patient comes to the cath lab due to CT scan planning. Where should it be done and who should be doing it? So there are a number of cardiac surgeons around the world who perform this procedure in conjunction with cardiologists, and I think that in many countries is the way forward. There is a debate whether or not these procedures should be performed in isolation in small hospitals or should be part of a larger group of heart team where all the options that you mentioned about a particular age group are available, so a more joint up decision can be made about the lifetime management of these patients. But that remains controversial. In terms of devices, there are a number of devices available, and it's growing, and they have evolved. For example, I'll mention this particular new kid on block, you could call it, is made up of a bioengineered tissue. So we are also moving in the direction of, as you learned, that man-made tissue can be used in this situation. By and large, we will divide them by how tall the frame is, because that has implications for you if these patients were to come back for surgery. If you implant a very tall frame and these patients then need surgery, that is pretty much guaranteed aortic valve root replacement, whereas if you put a short frame, they can be operated upon as if you don't need to do root replacement. The other factors are supraannular versus intraannular leaflets that determines hemodynamic performance. Whether or not that hemodynamic performance translates into durability of one particular device over other remains unknown. Then the method of deployment, self-expanding or balloon expandable, and porcine versus bovine pericardium. And again, all of these things we're learning from surgical colleagues about the benefit of one over the other. And I think Resilia tissue technology was mentioned, and modern balloon expandable valve available to use today now have the same leaflet technology that you will implant surgically. So leaflets are the same. Now, a big question had been in previous years about the durability of TAVI. It's not that TAVI was a low-risk procedure and the patient could go home the next day. That is no longer the bar. The bar is durability, how long these tissue would last. And the reason I mentioned, if there's one trial you must read, is this Notion trial, which was carried out in Nordic countries, a low-risk surgical patient, albeit older, mean age was 79. That's the only randomized trial with a long-term follow-up, which wasn't directly sponsored by industry, and shows very clearly there is good news. There is no big difference between TAVI and surgery, so these patients can have both treatment. But what is interesting is that the durability of THV, which was a question, is as good, if not better, than surgical bioprosthesis. There is some criticism of the surgical bioprosthesis used because there was some mitral flow in this, and as we heard, the performance of mitral flow wasn't as good as other surgical valves. And from TAVI operators, you could say that this data belongs exclusively to tall frame supraannular valve, or whether or not we can extrapolate to other valves remains unknown. And this is, again, the same trial, and it shows the severe bioprosthetic valve dysfunction. Now, why this is important, why I'm emphasizing about this, is that until this data, all the data we had previously, the endpoint for surgical bioprosthesis was freedom from reoperation. And you can use that surrogate, but it's just a surrogate. It gives you an idea, because many patients will be turned down for surgery for other reasons, not that the valve has failed or not. But this is core lab analysis, as good as it gets, echocardiographic data, or up to 10 years. The criticism is numbers are very small. As you can see, it's a small trial, it's not a large trial, but it's randomized. Now, if you put this in context, and all the trials, randomized trials that's been done so far, and you can look at this surgical aortic valve replacement and TAVI, you can see there is no signal to suggest that transcatheter heart valve fail quickly. And we know from trifecta data that if that was happening, it will surface very, very quickly, and it hasn't thus far. Okay, so that was for trileaflet valve, transfemoral access, no anatomical exclusion, no concomitant valve disease. What if you have a bicuspid aortic valve? What happens? So bicuspid aortic valves were excluded from the randomized controlled trial comparing TAVI and SAVAGE. So if you are a purist, the trial data does not apply to the bicuspid aortic valve. But if you look at the data altogether, a lot of these cases are performed. So if you look at the difference between tricuspid and bicuspid, there is a very clear signal, albeit still low risk. There's increased risk of stroke with bicuspid aortic valve if you have TAVI, which is understandable. They often have very heavy calcification. And there is a slightly higher risk of annular rupture with bicuspid anatomy. So these patients are at higher risk. And when you're making those decisions based on age and risk, you may need to take this into consideration. What about alternative access? What if it's not transfemoral TAVI? Should you let your TAVI access these patients? So now this is observational data, but adjusted for risk. There does not seem to be a large difference between transfemoral access or non-transfemoral access if you adjust for the risk markers, because often the non-transfemoral access is in patients who have higher risk. And when you divide the different risks, it's very clear that transaortic and transapical carry higher risk, whereas transaxillary or transcarotid have the lowest risk. Across the pond in America, there is good split between transcarotid and transaxillary, whereas on the European side, transaxillary remains the predominant access for non-femoral TAVI. What about patients who have had previous surgical bioprosthesis? Again, the decision has to be individualized. TAVI is very successful, a very low-risk procedure, but TAVI is not going to treat your patient-prosthetic mismatch or the risk of the patient-prosthetic mismatch. So if there is a baseline patient-prosthetic mismatch, that cannot be treated by TAVI, even if you can do what we call bioprosthetic valve fracture, as demonstrated here. There are valves that you can fracture and put a bigger valve than the original bioprosthesis. So if you are going to ever listen to your cardiologist, please do not put Hancocks, because we can't modify, we can't make them bigger. And trifecta, you're very well aware, we're not going down that route. But most valves can be either modified or fractured. And then what you get in them has different performance. As you can see, loads of redundancies there, whereas this is better expansion. Right. So, what happens if you do TAVI after surgical aortic valve replacement? Is it as good as surgery? Is it better? So the data, again, is all observational data, but large numbers in this meta-analysis here. You can see that for short-term outcomes, 30-day mortality, major bleeding, severe patient-prosthetic mismatch, there are differences. So if you have patient-prosthetic mismatch, it still favors redo surgery rather than TAVI, although you can perform a low-risk procedure. What about TAVI and TAVI? So if you have done a TAVI before, do they all need to have surgery? If a patient has endocarditis, they don't have a choice. We would be asking you if their risk is not prohibitive. What we know from explant registry is that the surgical mortality is somewhere between 12 to 25% if you operate on someone who's got TAVI, but that's also tainted by the fact that TAVI so far has been performed in older individuals with higher risk. I think that technique will improve for surgeons of future. I think you would not have any choice but to get experience in explanting TAVIs, because this is going to happen. Numbers may be small, but it's going to happen in future. So what we know about if you were to do TAVI in TAVI is the risk remains very similar to as that of TAVI in SAVR. Now, before I go any further and talk a little bit about the lifetime management, this is a very pertinent slide, and I thought that I should share it with you because although average expected survival at age 60 is, depending upon gender, somewhere between 23 to 25 years. And it's about 15 to 17 years at age 70. But the patients who are having aortic valve intervention, whether they are having TAVI or SAVR, they're not really your average citizen. They do have other problems. And this is Nordic data with very good completeness, and I would encourage that surgeons read this paper as well. So you can see, depending upon your risk, your survival, even at age 65, may not be 15 years. And that has to be taken into account when we are deciding whether the patient should have surgical aortic valve replacement or TAVI. What other factors should be considered? As we discussed, if the patient is female and they want to have family, then you might want to start with the Ross procedure. If that's not the consideration, of course, they can have surgical aortic valve replacement with mechanical valve. Should first press procedure always be surgical aortic valve replacement? That will depend upon what is expected survival. So, when we're talking about a lifelong management, this could be done in many different orders, and that's why it will be very difficult to show which combination will do best, because you could have, as you can see from here, numerous combinations, and you would require very long follow-up. And that actually means that as all of these procedures, a straightforward isolated aortic valve replacement surgically or TAVI become less and less complex, the decision-making is much more complex. Briefly about TAVI in aortic regurgitation, that is the last frontier, but there is now a dedicated device that is available, that's being tested in studies, and is already available in common use. That is called the Trilogy, or it is also known as JenaValve. And you can now treat aortic valves which do not have any calcification, and the mechanism of failure is pure aortic regurgitation as long as it's not bicuspid. When we have used TAVI valve designed for aortic stenosis, the outcomes are not that great. There is higher risk of embolization or migration towards ventricle. So unless they are prohibitive or very high surgical risk, and you do not have access to Trilogy, or they are not suitable for that, then you can put balloon expandable or self-expanding valve, but it should be avoided if possible. So my final comments would be that TAVI is here, and it's being done in all risk spectrum. So risk is no longer the consideration. The consideration is anatomical and clinical factors and their expected survival. And I think the CNs are increasingly more complex and should be done as a part of hard team. And for that reason, multidisciplinary teams plays more important role than it did before. In bicuspid valve, TAVI can be done, but it's still outside the randomized control data. So I think bicuspid aortic valve, especially type 0s or heavily calcified one, are for surgeon unless there's good reason not to. Valve durability, again, the question has been answered as clearly as possible with the best data that we can generate with current scientific methods, and I think it's very clear that whether you put biprosthetic surgical aortic valve or THV, they last up to 10 years very easily, with very low failure or reintervention rate. And coming back to the patient that I sent you the scenario earlier, they could have technically a straightforward valve inside that small trifecta, which cannot be made bigger. She has small or shallow sinuses. There's very high risk of PPM, even though she didn't have PPM at the baseline. And our MDT discussion was that she should have surgical aortic valve replacement rather than TAVI, and that's what she did, and she did well. So I'll take any question you might have, or we'll go into